So I'll be talking about travel medicine in the age of COVID. I mean, thankfully, COVID, I mean, it's really different now in comparison to a year ago or so when we had a lot of regulations, testing and quarantine and all that. Then most of the countries got rid of that. So thankfully, so there's more travel now. So no disclosures. So objectives, going over the risks, how to make recommendations, COVID, and also talking about points for traveling with children. So with that, the risk assessment, it's really where are you going and when? So really, it's different when you're going to Canada versus sub-Saharan Africa for sure. Are there any outbreaks at that destination? As for the timing, what season? Is it winter? Is it summer? Are mosquitoes out? Are ticks out? Time to departure too. Are you leaving tomorrow? Are you leaving in a month? Because our recommendations would change depending on when they're leaving. And also, how long are you going to be there? Are you going to be there for 3 days for business versus are you moving there to live there? So, and as to why are you going? I mean, most times, I would say majority of the time, I see patients who go for sightseeing, so tourism. But among these, the one that has relatively risk for acquiring infection is actually the one on the right, visiting friends and relatives. That group tend to have more risks acquiring infection. And how are you going to spend time there? So really, it's really different if someone's camping versus staying at a 4-star hotel. Adventurous eating, I put that down, but it's more for what I meant by that is like unpasteurized milk, because that would put you at risk for things like listeria, salmonella, brucella, E. coli, and so a lot of things. So pasteurization is really good, that it prevents infections. So I'll talk about travel with children. So before I go into immunizations, how many of you do routine travel counseling? Great. Some of you, great. Yeah, because the thing with primary care is that, you may do the annual exam and maybe, like towards the end of the visit, they may say, by the way, actually in a month or so, I'm going to sub-Saharan Africa and we'll be going on this safari trip or something like that. And you can say, great, have a nice trip, but there are things that you could counsel them about. So the things I'll be going over, immunizations is one, malaria prophylaxis is another, and then the other is traveler's diarrhea. So first, immunizations. So it really is a good time to not just go over travel-related vaccines, but routine vaccines. So Tdap, MMR, and so forth. But I did see that there is a talk this afternoon about routine vaccinations, but it really is a good time to make sure everyone is caught up with the vaccines. So the other thing to think about is really what's the risk of getting infections during these trips. So this is for about an incidence per month for vaccine preventable diseases, going to a lower income countries among non-immune Western travelers. So the highest is flu, which is 1 in 100. And you could go down, it's not too high. Japanese encephalitis is 1 in a million. And then even lower meningococcal, cholera, yellow fever. So we take that into account as well. So the first vaccine that I'm going to talk about is yellow fever. So yellow fever virus itself is in Africa and South America and a little bit of Central America in Panama up till the Panama Canal, but not in Asia. So really Africa and South America mainly. So the reason why I bring up yellow fever vaccine first is because it may be a vaccine where it's needed to enter a certain country. So you need a proof of vaccination to enter a certain country. It's recommended for all travelers 9 months and older where there is yellow fever risk. And it changed maybe 10 years ago or so. But one dose of yellow fever vaccine is lifelong. So it's good for life. Before, it used to be we have to get a booster every 10 years, but that changed 10 years ago. You could consider booster if someone was pregnant when they had the initial dose, or if they're infected with HIV, or they had a stem cell transplant, or if there is a current outbreak going on at that destination. So you might have all seen this yellow fever card. These could be purchased from the government. Actually, it's about $1 a card. So there are, how to fill it out. So the name, the date of birth, sex of the traveler, the citizenship, then the passport number. So and then they have to sign it. So I usually have the traveler fill that part out. And then below that, you put yellow fever, because that is what this card is for. And then toward the bottom at the table, so yellow fever. And then the next column, you put the date you immunize the patient. You give the vaccine, then you sign it. And then you have to put the lot number, the batch number. And then after that, it's 10 days after you do the vaccine. So if you do it today, then you put down September 18th, 2023, and then for the life of the person vaccinated. And then after that, the long column, that's where you put stamp the vaccine. You put your stamp. And I'll tell you later how you get that stamp. How many of you have that yellow fever stamp at this point? 1, 2, some 3. Okay, great. Okay, so the thing with yellow fever vaccine is that it's not just that it's required to enter a few countries or some countries, but also that it's a live vaccine. So there are certainly risks associated with these live vaccines. So one of them is neurologic disease. So it could manifest in a lot of ways: Guillain-Barré, meningoencephalitis. Onset could be 2 to 56 days after the vaccination. It's not usually not fatal, although there are consequences. And the incidence is about 0.8 per 100,000. But if you're older than 60, it's higher, 2.2 per 100,000. So the other more serious one is viscerotropic disease. So it's really it's like getting the yellow fever itself. So multi-organ failure, about half the time people die. The incubation period is shorter. Onset is usually 4 days, and it's less frequent in comparison to the neurotropic disease, 0.3 per 100,000, but for 60 and older, it's 1.2. So these are things that we have to counsel patients on, or the travelers on. And then these are absolute contraindications. So infants, age less than 6 months, allergies, obviously, HIV if the CD4 is less than 200, and other immunodeficiencies, including thymus disorder and transplantation, where they are because this is a live vaccine, they are at higher risk for these complications. And then these are precautions, not absolute contraindications, but relative contraindications. So you could, an infant could get one at 6 to 8 months. You could, 60 and older, you could get one too. Breastfeeding, HIV, CD4 between 200 and 499, and pregnancy too. That's not a absolute contraindication, although we try to see if the traveler could postpone that trip if they're pregnant, because it's not just yellow fever they're at risk for. There are a lot of risk for other things too. So for those travelers with contraindications, there's on that yellow fever card, there's a part where you could put in the medical contraindication to vaccination. So you put the name of the disease, so yellow fever, for the traveler is medically contraindicated because of the following conditions, and you could just fill it out. And then I actually create another similar content, but on a letterhead, so that it looks official too. So they'll have this card an official letter from our institution as well, and we just sign it. But I just also tell the patient or the traveler too, is that at immigration, they may or may not accept it, because there is a chance that they may not accept this contraindication. And those times, I haven't had any of my travelers, but I've heard of people getting vaccinated at that border, although and to get into the country, because many times going to these countries are their, it's their really, lifetime event to go to these countries, and of course they don't want to be turned back because of a vaccine. So but it is a yellow fever vaccine is a big deal. So this is so how you can get that certification. So this is from the website from the Department of Health in Washington. So first, you have to do a CDC webinar on yellow fever vaccine. This takes about maybe 2 hours or so. It's really going over the things that I just went over pretty much. That it's a live vaccine and there are absolute and relative contraindications. Number two, you provider application. So that's like your address and where can the vaccines be mailed to and things like that. For a pharmacist, there's an extra step. But once it's approved, you get a letter of certification from DOH, and then they'll tell you how to order the official stamp. And then the vaccine manufacturer, they will be notified too, because you can't just order them, because they have to have your institution and your name associated, or they won't send you the vaccine. And then your name and the facility will be added to the CDC National Registry. And the other point is that it has to be renewed every 3 years. So it's not like you one and done, you have to do it every 3 years. So the second vaccine is a meningococcal vaccine that I'm going to talk about. So this is Africa, and there's a meningococcal belt across Africa. So most risk during December to June. It's a quadrivalent conjugate vaccine, not the Men-B vaccine, but the 4-ACWY one. So the reason why I have the second is that Saudi Arabia requires it if you're traveling for a pilgrimage. So it has to be given 10 days or between 10 days and 3 years before arrival to Saudi Arabia to enter the country for the pilgrimage. So I have a few others. So typhoid vaccine. So this is fecal oral. It's Salmonella typhi. So there are two vaccines. There's the oral one. So that's live. It's age 6 and older, and it's good for 5 years. You have to take the capsule every other day, which needs to be refrigerated. So complete 1 week before travel. For some reason, I wrote it twice, but 1 week before travel. Because it's a attenuated bacteria, you can't be on antibiotics because it'll kill it. then you won't get that immunity. So no antibiotics so that you build that immunity. And then there's the IM form, which is good for 2 years and for 2 years and older. And then it's good in 50 to 80%. As for typhoid fever, the most common place, I would say over 80% of the time, the place that the traveler gets it is South Asia. So that would be India, Pakistan, Nepal, Sri Lanka. So those are I would say that would be the high priority if a traveler is going there. So Japanese encephalitis, similar to yellow fever in a sense that it's mosquito-borne, but it's Asia. But as I said, the case is relatively rare, 1 case per million. And there's a 2-shot series now for age between 18 and 64. 1 shot really is not effective. You have to get 2 to get that efficacy. Polio, nowadays, the wild type is only in 3 places. It's Afghanistan, it's Pakistan, and Mozambique. The rest are actually vaccine-derived polio, because here in the US, we don't have a live polio vaccine, but in other countries, they use oral live polio vaccine. And with that, they shed it in the stool, and then people around them could get polio, the vaccine-derived polio. So there are a lot more of that than the wild type nowadays. And you might have heard there was a case in New York too this year, this year. So hepatitis A, this is, I mean, nowadays, everyone or most of us should be getting it, but the most common vaccine preventable infections is direct person to person or contaminated food or water. Freezing does not inactivate the virus. You might have heard there was an outbreak in Washington State this year, March, April or so. There was a recall for frozen strawberries from Mexico. There were, I think there were just 10 cases total, but 6 were in Washington. I think the recalls were in like Costco, Trader Joe's, I think PCC Market. There were 6 cases, 2 were admitted. Out of the 6, 3 were King County, 2 were Snohomish, and 1 was Kittitas. Unfortunately, no one died. But this has been happening over the last 10 years. And there's also outbreaks among the homeless population. So if you see them in the hospital or in clinic, you really do want to make sure they're vaccinated. And it's a 2-shot series, and it's good for life. So rabies is another one. It could be here or, travel related or not. But it's really among all mammals. Here in the US, it's bats. We hear about, someone waking up with a bat in their room or something like that. For travelers, pre-exposure prophylaxis is 2-shot, day 0 and then a week later. And what I try to counsel them is if they do get bit, really make sure they clean wherever the wound is to see if we could not just avoid rabies, but also like a wound infection as well. And if you've been vaccinated, it's just a 2-shot series after that. But if you haven't, then it's immunoglobulins around the wound plus 4 more doses of the vaccine. This is usually very effective, but you might have seen there was a case in Minnesota 2 years ago where a person woke up when the bat bit the patient's hand, and a few days later he did the immunoglobulins and the vaccines, but died 5 months later from rabies. So this is not 100%, but this is usually effective. So tick-borne encephalitis, this is the last travel-related vaccine. So tick-borne encephalitis, you don't think of like Europe as a place where you need a extra vaccine for, but as the name implies, it's a tick-borne illness. So ticks, so spring and summer, not during the winter time. So adventurous eaters, so indications, so you could get it from unpasteurized milk, dairy. So that's one. So if you live in places with, in the woods. So with that, the thing with this one is that it was just approved a few years ago, but it's a 3-shot series. So the reason why I mentioned, initially about like, when are you traveling? Because this is difficult because, it's a 3-shot series. So 0, 14 days to 3 months. And then the third one's 5 to 12 months later. And we rarely see them. So it really depends on are they going back there again or not? Then decide if they need to get this vaccine. So with that, from immunizations, the second big counseling that we do is for malaria prevention. So really, is there malaria there? Then how can we prevent bites, not for malaria, not just malaria, but Zika and chikungunya and dengue and everything else? And is there medications that could be taken? I won't talk too much about diagnosis and early detection, but anyone with fever, getting a travel history is important. As for malaria, falciparum, you would see them within a month. But something with like a hypnozoite phase, like Ovali or Vivax, it could be months to sometimes years before you manifest with symptoms. So awareness of risk. So the biggest risk category, children. So in developing countries where it's endemic, so among the fatalities in the world, close to 80% are children. So age less than 5. So in those countries now, they have developed the vaccine but not for travelers. But obviously long-term travelers, pregnant women, and then sub-Saharan Africa is the highest risk. Obviously, if you're not taking chemoprophylaxis, you're at risk. And then, as I mentioned before, visiting friends and relatives are at higher risk for acquiring Plasmodium species malaria. And you may have seen this in the news, but this is from the CDC. So this was in June that there were cases locally acquired malaria in Florida and Texas. So this was in June. So no travel history either. So I mean, with warming of the globe and climate change and all that, we might see that rise or change in the incidence of these tropical infections that we thought was tropical and maybe not so much. And then, sorry, this is small, but reviewing for this talk, I found another one, Maryland. Maryland had a case too. And this was Plasmodium falciparum that they found in the DC area with someone who had no travel history. So we certainly are seeing, it certainly could be on your differential diagnosis for fever in these patients, even without travel. So then you think about so what's the risk? Is there malaria in the place that they're traveling or not? So and the CDC there's a CDC yellow book. You could buy the book itself, or the content is available online free. So if you go to Ecuador, let's say, so areas less than 1,500 meters and all these provinces, there's a risk, rare in other provinces, and then nothing in Guayaquil or Quito or Galapagos Islands. I'm not too familiar with with Ecuador per se. I don't know any of these provinces. But so in the CDC Yellow Book, there are limited maps that are there. So in our clinic, we use Travax. There are other programs out there too. There's a new one called Travel Care. There's another one called TropiMed. Those are really subscriptions that you pay to get these information, and they are updated frequently, and they'll tell you about any outbreaks in these places. So this is just a sample map from Travax, but the red areas are where there is definitely malaria and definitely recommended to get the chemoprophylaxis. A little bit of the checkered places, it really depends on your activity. Are you going to be outdoors a lot? Then maybe consider white are the places where there is no malaria, and then the dotted places, there may be, but not significant. So this is something that we go over, we show the traveler and go over really where are you going, and so that we could determine is there an indication for malaria prophylaxis or not. So bite prevention, as I said, it's not just malaria, it's for Zika, it's for dengue, it's for chikungunya, it's for Chagas. So it's really any insect-borne illness. So DEET is good, Picaridin is good. The thing with it is that it doesn't last too long depending on the formulation. At least so the shortest one would be every 2 to 4 hours. There's some that last 6 to 13 hours, but it has to be reapplied. And many of these places it's sunny, tropical. So you usually apply the sunscreen first, then put the skin repellent over that. And if you can, long sleeves, protect the skin, permethrin treated clothing, or you could treat the clothing itself with permethrin, check for ticks, and then sleep under bed nets. Those are some of the strategies. And chemoprophylaxis, because this is a part that you have to do, do they need it, and then which one, and so forth. So these are some of the common ones that we prescribe. So atovacone proguanil, that's Malarone is the other name for it. You could use it worldwide. It's 1 tablet daily, 1 to 2 days before, every day that you're there, and then for 7 days after. It's effective, it's tolerated. The only thing is that, someone with kidney disease, it's contraindicated. Doxycycline, it's again worldwide use, similar, but you have to take it 28 days post-travel, so it's longer. So it's antibacterial too, so it covers for rickettsia and leptospira too. It's likely the least expensive, but you have to go over the side effects too. So nausea, photosensitivity. I mean, some patients have told me they could feel the skin sizzle. Esophagitis, that's pill esophagitis, really making sure that the pill makes it down to the stomach because they could, cause severe esophagitis. So don't lie down right after they take it. So chloroquine, hydroxychloroquine. So the issue with this one is it's weekly, but there's a lot of resistance out there. So Central America and Caribbean, they're okay, but not other places. So you could do chloroquine, hydroxychloroquine, because sometimes you have a patient with like lupus or something, and they're on hydroxychloroquine, and they'll ask, it has anti-malarial effect. Do I need to take Malarone or doxycycline? But it really depends on their destination. Because as I said, if they are going to sub-Saharan Africa, it won't be effective. The dose they're getting is usually 200 to 400 milligram daily. So it's not the dose issue, but it's the resistance issue. But it's really limited to Central America and Caribbean. Mefloquine is another weekly one. There's some resistance, but the issue with mefloquine is that it has CNS potential for CNS side effects. So you have to be careful with someone who has depression or anxiety or seizure, psychosis. So it's not as well tolerated as like Malarone. Hepanoquine is a new one. The issue with this one is that we have to check for G6PD, just like Primaquine, so that they don't get hemolytic anemia. So, but this is the newest one. So as for malaria, so really, is there a risk? What can we do to prevent bites, mosquito bites? And then really, if indicated, what kind of prophylactic anti-malaria could we give? So traveler's diarrhea is the next big one that we discuss. So traveler's diarrhea. So this is way more common than the vaccine preventable diseases. So boil it, cook it, peel it, or forget it. You might have heard that. But also there are studies that say that people who practice that versus not, there really hadn't been significant change in the incidence of traveler's diarrhea. So does it not work? It may not work, but the issue is not that. It's the more issue with the restaurant that they go to, or really the overall sanitation issue in those countries. Usually it's bacterial. As you know, it's toxigenic E. coli is the most common. You could get virus like norovirus, and protozoa like Giardia or Cryptosporidium. So boil it, cook it, peel it, or forget it. But I still would recommend food and water precautions. So avoiding salads. If it's a food of animal origin, making sure it's cooked thoroughly. The least risk is if you cook it yourself, but how often do you cook? Yeah, I don't know. I wouldn't. So I don't cook myself right now. So I don't foresee myself cooking while I'm traveling, but washing hands and avoiding tap water as well as ice made from water. So incidence rate of traveler's diarrhea is really, there's a lot out there. Like even the blue, which is the least incidence, it's less than 8%. So it's very common. So treatment, it's really similar to the first talk, where really, do we need to give antibiotics or not? And the trend has changed over the last decade or so. So if it's mild diarrhea and you could tolerate, you could do your activities, don't take antibiotics. Just do bismuth or loperamide. If it's moderate, yeah, it's distressing, maybe interferes, you could consider these antibiotics. Azithromycin, usually 500 daily or 1 gram times 1, or fluoroquinolones like Cipro, 500 PO/BID, or rifaximin. And you could consider loperamide too. So the only time that it's really recommended to take antibiotic, severe diarrhea, so incapacitating, or really you can't do the planned activities, or dysentery. So that's in comparison to water diarrhea. So if you see blood, or if you see mucus in the stool, or if they're febrile, or they're having significant abdominal pain, then that would be a time to take these antibiotics. So in those cases, azithromycin is preferred. So as I said, gram times 1 or 500 PO daily times 3. Quinolones, rifaximin for non-dysenteric diarrhea. So it's like watery diarrhea. And usually not just monotherapy with like loperamide. And the reason why the recommendation moved to this is because patients who go to a developing country and take antibiotics, actually they come back to their country with these multi-drug resistant organisms. So it's not like, yeah, the diarrhea is better, but they come home with resistant organisms, like you might have heard of NDM1 E. coli. So that's a carbapenem resistant E. coli. So that's why the recommendation now is to really let's just hold off on antibiotics if we could. So COVID, because so I'll talk about COVID. So not too long. So as you can see, this is the new hospital admissions by week. I just got this 3 days ago, but as you can see, it's rising. You might have experienced this. I mean, I certainly see this in my hospital, not like before, but it is on the rise, and hopefully we'll get that updated vaccine soon. So the most recent variants are two, the Eris, EG5, and FL151 Fornax. So those are both on the rise for several months now. It hasn't peaked. The relative good news, it's relative good news is that Moderna and Pfizer, they both said that at least there is significant boost in neutralizing antibodies against these variants. So hopefully we get the updated vaccine later this month, maybe in a few weeks, and hopefully that will get that incidence of hospitalization lower. So for COVID-19, for travel, really making sure vaccination is up to date. So, some patients ask me, so should I get the current booster? I usually say hold off because the new one's coming in a few weeks. And then previously we used to say that you get your boost, you get your vaccine and then you wait for the second one for a few months. So, and I don't know how effective the current one is either. So I usually say to wait a few more weeks and just get that one. And for travelers, really, what's the risk factor for severe disease? So that's like age, obesity, underlying any heart disease, lung disease, things like that. And really, are there COVID circulating in that country? And then if you have test kits, bring them so that you could test yourself if you get sick. And then nirmatrelvir and ritonavir. So that's the other name for Paxlovid. So I don't know if you've heard, I don't know how much prescription you do for Paxlovid, but there are some travelers who like, if I do get sick, what do I do? Can I have a prescription? So so this is from the FDA website. So I'm traveling soon. Can I receive Paxlovid under the EUA prior to travel in case I become sick with COVID-19? So they're not clear. They don't say yes or no, but they say like at time of prescription, like that the patient has mild to moderate COVID, but then they are asymptomatic when you're counseling. So does this mean no? Then risk for disease progression. So what they mean is like you won't give it to a 30-year-old who is otherwise healthy because you wouldn't get it here. Well, why would you get it during travel? And then the other part is a drug-drug interaction because the atovaquone proguanil that I talked about, which is the most commonly prescribed antibiotic for malaria prophylaxis, there is interaction. Is it significant? Perhaps. There is. So it's atovaquone and proguanil, and ritonavir, part of the Paxlovid, lowers the amount of both drugs for malaria prophylaxis. Then you can argue, well, someone has COVID, they shouldn't be out and about, getting bit by mosquitoes. But those are the things that you have to talk to the patient about. So this is not a clear yes or no, but it's really with discussion with the patient and really counseling. So traveling with children, I'm not a pediatrician, but there are a few slides regarding this. So as for vaccines, again, it's a good time to talk about routine vaccines and travel vaccines. And there are age restrictions for certain children too. And then talk about refusal. It's just not for children, but also for adults too. So why do patients or travelers refuse vaccines? This is over 10 years ago, but is it too expensive? Is it a safety issue? Are they concerned about the vaccine side effects? Or is it, yeah, no, I won't I won't, I've never had, you probably heard this, I've never had flu, I'm not gonna get the flu vaccine. So things like that. So with that, so this was from 10 years ago, but so the biggest part is that they're not concerned with illness, like flu, like 80%. They're not concerned about the vaccine safety or the cost, but it's really, they're not concerned about the illness. So it's really, knowing that, it's really how do you counsel these patients or travelers to get these vaccines? And there are some vaccines that are really expensive too, like some could be $500 or more, or if you're doing the course, it's going to be over 1,000. And you can see that with Japanese encephalitis. Yeah, it could be expensive, including rabies and yellow fever too. So other tips for children, so liquid medications if possible. Bring car seats, because many of the developing countries may not have car seats. And for the medical kits, bring that COVID kit, and then all these over-the-counter medications, including topical stuff and acetaminophen, ibuprofen, antihistamines, and GI stuff too. So I talked about all these ID issues, but let me talk about the non-infectious issues too with travel. So this is 20 years ago, but as you can see, the most fatalities are traffic accidents. Number 2 is cardiovascular, then drowning. Infection, dying from infection is really low, 1.4%. And if you even include the unknown illnesses, it's still the traffic accidents and the cardiovascular are way up there. And this is more recent study among US citizens, but motor vehicle accident is the highest for risk for death. And then, I showed this earlier today, or earlier slide, but really the risk of infection is not too high, although this wouldn't be, this is something to talk to the patient about the risk of these infections and deciding to vaccinate or not. And the other part is your current insurance probably would not cover international medical care if you do get sick. And travel insurance that you get usually would cover for lost baggage or trip cancellation, but not for medical care or medevac if you need to. So with that, depending on your travel duration, where you're going, and what you want covered, these are some of the places that you could, or the traveler could look to see really if it's someone who's immunocompromised, heart disease or something. These are the places where you could get a quote as to really, if you need a medevac from Kenya or something, where do you go and how? So these are some of the places you could get that. So that was the last slide. So take home points, so assess risk for travel. It really depends on where, when, how, and why you're going. As for reviewing vaccines, doing the routine and the travel vaccines, malaria prevention, it's really, is there a risk? You have to do something to prevent insect bites, and then is there a indication for malaria prophylaxis? And then having it on the differential diagnosis for any traveler to endemic areas. Food, water precautions, traveler's diarrhea. Nowadays, the threshold for giving antibiotics or taking antibiotics is higher because of its risk. Non-infectious disease risks, as I mentioned, like the motor vehicle accidents, and for making sure you take a medical kit, including a COVID kit, and then looking into medical evacuation insurance if you feel like that potential. Thank you. Okay, cool.
This Dr. Chua. The question is, how do you deal with the people who's going on a food tour? Because sometimes they'll eat sushi and like raw oysters, and how do you prevent that? Because I remember a case in which patient had paratyphoid despite getting typhoid vaccine.
Yeah, so I think those cases, because if the thing is, it's really weighing the risk benefit, and it seems like some of these travelers are willing to take that risk. So with that, I think we just have to, I mean, there is so much prevention that we could do. So I think there isn't a great great advice other than to monitor their symptoms. If it's really significant, take that antibiotic and take that exposure into account, then see, is it E. coli, is it Vibrio, things like that. Because I know there are patients who are willing to jump into a water known to have schistosoma, and because the lake is so beautiful, but they're willing to take that risk. So I think it's really monitoring that symptoms and taking that exposure into account.
The medical contraindications for hydroxychloroquine, you listed about 3 of them. Psoriasis was one of them. And why is that? Or what's the contraindication?
Yeah, so I think that's because of the risk for flare of the psoriasis. So that's why. And then the thing with hydroxychloroquine and chloroquine is that it's so limited, meaning the geography, because it could be only used for Central America and Caribbean. And there are other options like atovaquone, proguanil, doxycycline, mefloquine. So that's why that's listed there as a potential flare risk.
Thank you.
First, a comment and then a question. On your slide, you mentioned, the slide mentions using 1% hydrocortisone cream. A cream is nothing more than an oil or grease and water. They do not mix. In order to get them to mix, they have to add emulsifying agents, then they get contaminated, then they add preservatives, and at this point, you're getting a bunch of stuff. If you were going to use cortisone, number one, it can be used very frequently. Second, it should be used on damp skin. Thirdly, it should be an ointment, not a cream. Hydrocortisone is non-prescription. It's very, very, very safe. We use it on babies. And so I would say, number one, change your slide from a cream to an ointment. Okay, that's the first comment. Second question has to do with COVID and vitamin D. Vitamin D is not a vitamin, it's a hormone. And what is the relationship and the effect or non-effect of COVID and the taking of good doses of vitamin D?
Okay, yeah. Thank you for the comment about hydrocortisone cream versus ointment. As for the vitamin D, I am not sure. I mean, yeah, I don't know. I don't know about vitamin D and effect on COVID, but there's a lot of things out there regarding vitamin D, and really is that the really needed. I mean, there's a lot of vitamin D supplements out there, and we test a lot for vitamin D, but yeah, I'm not sure the relationship between vitamin D and COVID.
Because of your presentation, you mentioned that the yellow fever vaccine is for life, but for certain individuals, they may need a booster. So at what interval after the initial vaccination do you give the booster if the person needs it?
Oh, so for the yellow fever vaccine?
Yes, sure.
Yeah, so it used to be 2014 and before. that, you get a booster every 10 years or so. So after that, in 2014 or so, there's been studies and the recommendation changed that it's good for life. So there are times boosters are indicated. So one, I listed on my slide, so like pregnancy, if a person was pregnant at the time of the vaccination, or if they had a stem transplant, or the other is if they're infected with HIV, those are to be considered. And the other is really, is there an outbreak situation at the destination? And those are reasons to get a booster. But otherwise, no, there's no need for a booster. Oh, if you need a booster, so it's 10 years. Yep.
Thank you for the great information. Can you tell us more about the vaccine for the ticks in Europe and the pathophysiology behind that?
Yeah, so
If you want.
oh, so you mean the for the tick-borne encephalitis?
Yes.
Yeah. So the thing with it is, as I showed on the map, it's from like Europe all the way across Asia through Russia to Japan too. So it's tick-borne, and it's so there are several types. There's like a Western European type, and then there's like a Siberian type. The Siberian type tends to be more severe, and could be has a fatality of like 1 to 2%. There are places in Europe where like Germany, where they do routine vaccination for their population. And there were a lot more in like because there's a base in like a US military base in Germany, where there used to be a lot during the 70s, and this tick-borne encephalitis vaccine is new to us, but there were ones in Europe before. So after the military people did get vaccinated, so there's been really decrease in the incidence of those encephalitis over the last few decades, actually.
My question is about the patient that has cirrhosis. What do you advise them in going to the like exposure to ocean and other activities?
Yeah, so I think so cirrhosis and ocean. So I think you're alluding to Vibrio vulnificus, because that's mainly in it's waterborne, and I think there's been rise in cases that we see. I think it's been reported in the CDC too recently. It used to be just in the Gulf, and now it's going up both coasts because Vibrio like warmer water. So yeah, so I think cirrhosis also it really depends on really the degree of the cirrhosis too, because if it's really, if it's decompensated versus compensated, I mean, if it could be helped, if they don't go in the water, that would be nice, that would be good, but it's really, it's that risk benefit. So if, counseling would be that, you would be at risk for all these bacterial infection if you were to go on the beach and go in the water where there is these bacteria. Any other questions?
The other thing is, how do you counsel these travelers, especially children? They go to Asia and there is a outbreak of dengue fever, and also this chikungunya and others.
Right. Yeah. So dengue is another one, just like malaria, where there is a vaccine, but not for travelers. It's for people who live in endemic areas. So dengue, chikungunya, Zika, the only thing that could be done is bite prevention. So that's DEET, long sleeves, and permethrin and bed nets. So unfortunately, there aren't too many things other than to just prevent those bites. Any other questions? Okay, well, thank you.